Came out about changes in H. pylori testing. We recognized there was a gap in physician knowledge about how to test, and Dr. Pylori graciously agreed to speak about it for us. Dr. Pylori went to medical school in India and then went to GI residency at the University of Iowa. Thank you.
Thank you. Well, thank you all for coming. Let's get started here. So these are the objectives of my talk today. So we're going to talk about the prevalence and the various clinical manifestations of H. pylori infections. We'll talk about diagnostic testing, what's available out there, what the limitations are of those tests, and then we'll talk about treatment regimens. Let's start with the epidemiology and the microbiology of Helicobacter pylori. It was discovered in the early 1980s. Drs. Warren and Marshall, who were Australian pathologists, I understand, did some work on patients with gastric cancer who passed away from the cancer, essentially autopsy samples, and discovered that the vast majority of them actually had this bacteria that they called Campylobacter pylori. And that was the original name of the bacteria. This discovery got them the Nobel Prize in 2005. Dr. Marshall subsequently passed away from gastric cancer from H. pylori. That's an interesting observation. So this is what it looks like. It's a flagellated bacterium. It actually is the most common chronic bacterial infection in humans. So worldwide, about half of humankind is affected with chronic H. pylori infection. So it's extremely common. So that you're talking about 3.5 billion people with H. pylori. In the U.S., 10% of 30-year-olds and about half of 60-year-olds have had H. pylori infection. It's more common in African Americans and in Hispanics compared to Caucasian patients. Patients who consume salty foods, which essentially is all Americans, have an increase in risk. The route of transmission is fecal-oral. So the H. pylori is shed in the stool of infected patients and is then subsequently spread to new patients from contamination. Now, it's interesting that even though it's a widely prevalent disease, reinfection is very uncommon. In other words, people who get the infection get adequately treated for it, eradicate the bacteria, and then get reinfected with a different strain. That's extremely uncommon. Recrudescence is very common. In other words, people get the infection, they treat it, we think it's eradicated, but it really is not, and then it comes back at some later stage. So it's a gram-negative spiral bacillus. It's very fastidious in growth requirements. It's microaerophilic. It requires carbon dioxide for growth. So in very aerobic environments, it is unable to thrive. It has a tuft of this unipolar flagella, as we saw, and it's especially adapted to thrive in the stomach. And here's how it adapts to the stomach. So there's three things that allow it to preferentially infect the gastric cavity, primarily the antrum. The first thing is it makes an enzyme. It makes a urease, which hydrolyzes the urea that's in the gastric lumen and forms ammonia. Ammonia then neutralizes gastric acid and forms this protective cloud around the organism, which enables it to penetrate the gastric mucosa. And then the shape of the bacteria, the spiral shape, the fact that it has flagellae, and also makes mucolytic enzymes, then allows it to dissolve, essentially, the mucous layer of the gastric mucosa and gain access to the gastric epithelial cells. And then there's some specific receptor-mediated adhesion mechanisms that allow it to adhere to the gastric epithelial cells. So this is a gram stain. Those seagull-shaped bacteria are what H. pylori looks like on a gram stain. This is an immunostain, or maybe a silver stain, bacteria on the surface of the gastric epithelium. So let's talk about infection and clinical manifestations. Now, as we were talking about, H. pylori primarily lives in the gastric mucosa. It's highly adaptive. The gastric antrum here is the favorite site for H. pylori infection. And you find it on the epithelial cells, but mostly on the mucus that overlies the mucosa. So, I mean, that's hard to biopsy on EGD, but if there's some way to actually take a mucus sample, that's where most of the bacteria are going to be. When H. pylori is acquired, the initial symptoms are pretty mild. You could have mild abdominal pain, mild nausea, mild gas, and some bad breath. So pretty non-specific symptoms. Some patients may not even have any symptoms in the acute phase. Now, H. pylori causes gastritis, not gastropathy. Now, the difference between the two, gastropathy is a kind of a chemical inflammation of the gastric mucosa, primarily caused by drugs, NSAIDs and so on, and alcohol, bile, people with congestive heart failure and other circulatory failures and chronic congestive processes. Now, gastritis is an inflammatory process, usually caused by infectious agents, H. pylori and other things. There's an autoimmune gastritis, and then some drugs that cause hypersensitivity reactions can also cause gastritis. So H. pylori causes gastritis, NSAIDs cause gastropathy. And this is how H. pylori progresses. So you have normal gastric mucosa. There's an acute H. pylori infection, which in the column here talks about level of acid production. So in the acute phase of infection, gastric acid production actually goes down when you first acquire H. pylori. And then over time, it kind of goes back up to where it used to be. So you have a chronic H. pylori infection. And then it can take one of three pathways, so to speak. You could either have an increase in gastric acid production, which causes an antral predominant gastritis, so inflammation just in the antrum, sparing the body and the fundus. And that is associated with increased gastric acid production, causing duodenal ulcers. You could have non-atrophic pangastritis, meaning the entire gastric mucosa is inflamed. And that in some patients can predispose to multiple lymphoma that we'll talk about in a minute. Or in the vast majority of patients, they stay asymptomatic over a period of time. There's also a corpus predominant, meaning a body predominant, so the mid part of the stomach, where there's actually decreased gastric acid production that then leads to gastric ulcer formation. That can also lead to intestinal metaplasia, eventually dysplasia, and then gastric adenocarcinoma. And it's very interesting, patients with gastric adenocarcinoma have very low levels of gastric acid production. And initially there was concern that PPI is predisposed to gastric cancers because of this correlation. But that's now shown not to be the case, that PPIs actually don't cause gastric cancer. So the outcome of the infection, and as we're talking about, it could take one of three pathways. It could be increased gastric acid, kind of normal gastric acid production, or decreased gastric acid production. And which pathway patients go into depend on the virulence of the strain that they acquire, environmental factors, and the genotype of the host. So clinical manifestations in chronic H. pylori gastritis affects 2/3 of the world's population at some point in their life. I mean, the prevalence is about 50%, but at 2/3 at some point in their life get chronic H. pylori gastritis. And there's various manifestations. We'll talk about each one in subsequent slides. So it can cause peptic ulcer disease, gastric cancer, adenocarcinoma. It can also cause lymphoma, a multiple lymphoma. And it does play a role in non-ulcer dyspepsia. This was initially controversial, and I think it's become less controversial over time. And then it does play a role in GERD, although it's not as straightforward as we think. So let's talk about each one, starting with peptic ulcer disease. As we're talking about, in the early stages of the infection, it's an antral predominant gastritis, which leads to acid hypersecretion and then duodenal ulcers. In the later stages, you have a corpus predominant or body predominant gastritis, which causes decreased acid secretion and gastric ulcers. About a half to 3/4 of duodenal ulcers have H. pylori positivities. To about a third to almost 95% of gastric ulcers. So H. pylori is very, very common in peptic ulcer disease. About a third to a half of gastric adenocarcinomas are due to H. pylori. I mean, we all know the relationship between H. pylori and mild lymphomas. Even gastric adenocarcinomas, up to half of them actually are associated with H. pylori. So getting infected increases your risk about sixfold. And the sequence, kind of like the adenoma carcinoma sequence in colon polyps, sequence is a superficial gastritis, which over time leads to chronic atrophic gastritis, that leads to intestinal hyperplasia, dysplasia, and then to cancer. And the vast majority of patients with the mild lymphoma, the new name for that is the extranodal marginal zone B-cell lymphoma. The vast majority of them have H. pylori. I mean, this is the only common cancer that's primarily due to a bacterial infection. Essentially, all of them have H. pylori infection. Now, let's talk about reflux disease. Now, intuitively, you would think if you have a chronic bacterial infection that changes gastric acid production, that it perhaps increases reflux symptoms, and treating the infection would improve reflux symptoms. So that's partially true. When patients have antral predominant gastritis, the somatostatin secreting D cells, so the D cells are primarily located in the gastric antrum. So the D cells are affected, and therefore less somatostatin is secreted. That then leads to a lack of feedback inhibition by luminal acid or gastrin release. So there's less D cells, there's less feedback inhibition. There's increased gastrin production, and therefore increased acid secretion. So in patients with antral predominant gastritis, if you eradicate the H. pylori, reflux symptoms actually improve because you are decreasing acid hypersecretion by treating those patients. However, if somebody has corpus predominant or pangastritis, they actually have increased gastrin levels and have decreased acid secretion. And in those patients, treating H. pylori actually worsens reflux symptoms. Now, most, in routine clinical practice, we do see antral predominant gastritis, but primarily this is what we see. And it's I'm sure Stella sees this all the time also. We identify patients with H. pylori, go and eradicate them. Initially they're better, but then they have symptoms again, and they come back saying, well, maybe I still have the infection, I'm not feeling a whole lot better. And some patients do. Some patients have persistent infection. But in many patients, their symptoms are actually from worsening reflux disease, because now the H. pylori is gone. So gastric acid production goes back to its normal level of production from being low. So with reflux, we have, that's not to say that you shouldn't eradicate H. pylori, but you just have to be aware that this can happen. Let's talk about testing now, who to test and how to test. So I'll talk about our society guidelines. These are the ACG guidelines on who to test. Now obviously with most things in medicine, you only have to do a test if you intend to act on the results. So test only, the intention is to treat. Just kind of screening is not recommended. So patients with uninvestigated dyspepsia who are younger than 55, that don't have your alarm features, your typical things, your weight loss, your blood in the stool, decreased appetite, family history of gastric cancer. So if they don't have any of those alarm features, and they've not been investigated otherwise, meaning they haven't had an endoscopy or other testing, in those patients, the recommendation is to test for H. pylori, if the intention then is to treat those patients if the H. pylori is positive. So there's a large group of patients who fall into that category. I would advocate testing these patients unless there's alarm feature. And most patients actually don't have alarm features, so I think we should be testing folks with dyspepsia. Now, patients with mild lymphomas obviously need to be tested, active ulcer disease, or past history of ulcer disease. Patients who are going to be on long-term treatment with PPIs also need to be tested. So these are folks who either have had a hip replacement recently, or they're going to be taking NSAIDs for a long time. they've been put on Plavix or something, and they're going to be on PPS for a long time. So I think it's reasonable to test these patients for H. pylori, get it eradicated, because of the concern that I was talking about earlier, that gastric acid secretion can increase risk of intestinal metaplasia and gastric cancer. In NSAIDs, I think it's reasonable to test. Folks with immune thrombocytopenia, also there's a recommendation to test, because active H. pylori infection can predispose to autoimmune thrombocytopenia. Patients with unexplained iron deficiency or vitamin B12 deficiency, and because of the association with chronic atrophic gastritis, also need to be tested. So you can see there's a lot of patients that really we can consider testing. And this is a summary slide on what tests are available. I'll quickly talk about it, then we'll talk about each test in a separate slide. And this comes from the New England Journal. I believe this was a 2012-11 publication, and it has not been updated since then. So there's two categories. There's non-endoscopic tests, and then there's endoscopic tests. So let's start with the non-endoscopic. So there's three options. There's your serologic testing, so IgM and IgG for H. pylori. We'll talk about it a little bit more. It's widely available. It's very inexpensive. It's very easy to do. It's just a blood test. The disadvantage is that a positive result could be a false positive. They not always indicate an active infection. They just indicate a previous infection with H. pylori. And it definitely is not recommended for confirming eradication of H. pylori. There's a urea breath test, which has high negative and positive predictive values. It's useful to diagnose the disease and also to confirm eradication. But there's false negatives that can happen when patients take PPIs or antibiotics or bismuth. And it's it takes a while to do it. You have to collect the breath sample, you have to run the samples, it takes some personnel. There's the fecal antigen test, which also has very high negative and positive predictive values, and can be used before and after treatment. The problem is it requires collecting stool, which some patients may not like. And it's also affected by using PPIs and antibiotics and this. Then there's three endoscopic tests. Now culture, which is down here, is not done anymore because it's very laborious, takes especially trained staff. So these are the two tests. We have various urease-based breath tests, which are rapid and expensive. They're pretty accurate, but they can also be affected by PPIs and antibiotics and bismuth. So there's many brand names, and the one that's commonly used is the flow test. And then there's the actual biopsies, which is good sensitivity and specificity. It requires trained pathology staff. So let's talk about each of these tests a little bit more. So serology, the IgG is the only test that should be done. The IgM is very inaccurate. Recommendations are not to, even though it's available, recommendations are not to use IgM testing. The sensitivity is pretty good. The specificity is not that great for the reasons that we talked about. It may not indicate an active infection. It would just be a chronic infection. Now, urease breath test. So the way this works is urea is hydrolyzed by the urease enzyme that's made by H. pylori. And that releases carbon dioxide and ammonia. And the patient, ingests a tagged carbon isotope. There's two kinds, there's the 13C and the 14C. And then they liberate carbon dioxide, which then is tagged with that radioactive carbon. And that's what the breath test tests. And it's pretty sensitive, and it's pretty specific. But again, it takes a while to do.
It's a labeled urea, or?
It's a labeled, so the what's exhaled is labeled carbon dioxide. So what the machine picks up is radio-labeled carbon dioxide, basically. We don't do this here. In my previous practice, we did do it. There's no reason not to do it. It's just it takes a while so the patients stay there for a while, provide breath samples, and that needs to be analyzed. And it's not that inexpensive. I'm not exactly sure how much it costs. Do you know, Steph?
We did used to do it here
Right.
in nuclear medicine when I first got here.
Right.
We don't order it, so it's not
Right.
done in.
So, and then there's the stool antigen assay, which is my personal favorite, and that's what our GI societies, all three of them, recommend as being the preferred non-invasive method for the primary diagnosis of H. pylori. Now, it's not a PCR, it's a enzyme immunoassay. It's highly sensitive and pretty specific as well. So stool antigen testing, the only drawback that I can see is that it requires collection of a stool sample. I mean, it's not expensive, it's pretty easy to do, but it requires collecting a stool sample. But it really is the recommended non-invasive method for diagnosis. Now, when we do biopsies from the gastric antrum during endoscopy, then we can place them into a little kit that comes that looks for urease activity, and the specificity of that is 100%. So if it's positive, you know it's there. There's no question. And it's pretty sensitive as well. So there's various brand names. There's a Clo test. There's a few others that I'm forgetting the name of. We also don't do this routinely, but in patients where you strongly suspect H. pylori, but previous biopsies have not shown it, I think it's worthwhile considering. Now, histology, which is looking at the actual biopsy sample, that's considered the gold standard. The additional advantages of biopsies is that it can evaluate for gastritis, intestinal dysplasia, atrophic gastritis, and involved lymphomas. Routine H&E stains are not recommended. They don't actually pick up H. pylori. So there's this quick stain that is the preferred method for H. pylori. There's immunostaining techniques. Silver stains are very expensive, but they're available. So we do the quick Jensen method here in our lab. So this is what it looks like. So there's all this neutrophilic inflammation of the gastric mucosa related to H. pylori. And there's mononuclear cells as well. That's very typical for H. pylori gastritis. And this is what an immunostain looks like. So it really stands out. It's pretty easy to see. But it's a little bit more expensive. Now, we talked about who to test and how to test. This slide talks about which patients do we need to confirm eradication of the infection. For patients who've had ulcers, documented ulcers related to H. pylori, I think after you've finished the treatment regimen, it's worthwhile to test them to confirm eradication of the infection. Patients have persistent symptoms. These are our patients who come in with dyspepsia. We test them, they have a positive test, and then we treat them and have persistent dyspepsia. So I think those patients need to be tested as well. Patients with mild lymphomas or who've had early gastric cancer resected also need to be tested. In terms of how to test, the two primary methods would be stool antigen testing, which is a recommended technique, or doing a urease breath test. But both of those require stopping PPIs for 4 to 6 weeks. So we shouldn't test patients for at least 4 to 6 weeks after they finish their treatment. And then they shouldn't be taking any more antibiotics or PPIs at this point in those 4 to 6 weeks. So if you don't do that, then they continue on PPIs, and then we do a test. That could be a false negative test. Now, in reality, this is hard. Right? So this is a patient who has gastritis or peptic ulcer disease or some other clinical manifestation of H. pylori. And to have them stop PPIs for 4 weeks is hard. I mean, you can tell them to do it, but many patients won't because they have more symptoms when they don't take PPIs. And that's the challenge.
H2 blockers don't cause false negatives?
They do at a lower rate, I understand. But it's still, because basically you suppress gastric acid production, you may get false negatives, basically. So in clinical practice, it becomes very hard. So we still end up testing them. And if it's positive, it's positive. I mean, it's not a false positive. So if you retest with the stool antigen and it comes back positive, it is a true positive. And then they need to be retreated. But if it's negative, it may still be positive. So it could be false negative. So that's the challenge. Let's talk about treatment regimen. this is the ACG guidelines. These are old guidelines. They came out in 2007. So this month, actually, a couple of weeks ago, there's updated guidelines that came out in gastroenterology. So these are the AGA guidelines, which is slightly different from these, and I'll talk about that in just a minute. But the guidelines that you were using, patients are not allergic to penicillin and have not received macrolide antibiotics previously. The recommendation is a standard dose PPI twice daily or Nexium once daily, plus erythromycin and amoxicillin at those dosages for 10 to 14 days. So that's kind of the primary recommendation. So it's a 3-drug regimen, so 2 antibiotics and a PPI for 10 to 14 days. Patients who are allergic to penicillin, we switch out the amoxicillin for metronidazole, and the other medications are similar. Patients who are allergic and have failed one course of treatment, in other words, these are folks with persistent H. pylori infection. The recommendation is now a 4-drug regimen with bismuth, metronidazole, tetracycline, and PPIs, or bismuth, metronidazole, tetracycline, and PPI. And the dosages are different. So you could easily use 500 or 375 4 times a day, again for 10 to 14 days. So up until, I guess, this month, the recommendation was to use the 3-drug regimen, so 2 antibiotics and a PPI, in all patients, unless you're treating persistent infection. And then the recommendation was to use the 4-drug regimen. Now that's not changed. The latest guidelines, it's not even published yet, so I don't have a slide on it. The latest guidelines looked at the prevalence of metronidazole resistance across the country. So it was previously believed that most patients who receive metronidazole actually respond to it, and that's now known not to be the case. So the rates of metronidazole resistance are high enough that they're essentially saying all patients get a 4-drug regimen, unless you live in a part of the country that has low metronidazole resistance. And I believe it's the northeast or the northwest, I can't remember, where they have a low rate of resistance. The rest of the country has a higher rate. So they actually are recommending a 4-drug regimen, the same regimen, for essentially everybody, even for an initial treatment. But we'll know more once the actual recommendations are published. Now, in terms of treatment efficacy, triple therapy is about 80% effective in primary eradication. So about a fifth of patients will not eradicate H. pylori with the 3-drug regimen. Adding another drug buys you another 8%. So we still have about a 12% of the population that don't respond to the 4-drug regimen. So patients who fail treatment, the options are to use an alternative regimen or to use 4-drug treatment for 10 to 14 days. And then when you retreat with triple therapy, 70% eradicate the infection. And with 4 drugs, you get 76%. So even then, it's not 100%. So your best chance of eradicating is at the first round of treatment. Subsequent rounds, your efficacy keeps going down. Now, in those patients, there's a few other options. There's in Europe, this is actually the preferred treatment regimen. So they actually use levofloxacin, omeprazole, nitazoxanide, which is Alenia, and doxycycline. So that's called the LOAD regimen. Only for 7 to 10 days. It's not 10 to 14 days. It can be as short as a week of treatment. And their eradication rates are up to 90% compared to their old regimen, which is lansoprazole, amoxicillin, and erythromycin, similar to what we use here. So this is what we do, and the data on that, let me go back a slide, is that it's about 80% effective. Now, the LOAD regimen, which is, again, a generic antibiotic, levofloxacin, omeprazole, nitazoxanide, and this is not generic, unfortunately. It is generic in Europe, but it's not generic here. It's Alenia. And then doxycycline, of course, is generic. So we talk about 3 antibiotics and omeprazole. No bismuth on this. In just 7 to 10 days, eradication rates of up to 90%. There's also a new drug that's in trials, Gonoprazole. It's an oral potassium competitive acid blocker. And taken in combination with antibiotics boosts eradication up to 98%. So it's not available yet, clinical, it's in phase 3 clinical trials. I'm sure it's going to be very expensive, so that will limit access to the vast majority of patients. But this, in my mind, is worth considering, at least in patients with persistent or recurrent infection because of the higher eradication rates. So in summary then, H. pylori is the most common chronic bacterial infection. It causes gastritis, peptic ulcer disease, and gastric cancers, adenocarcinoma, and lymphomas. So testing and treating of appropriate patients is recommended. And then we talked about combination therapy. That's all I have.
It's such a clear topic.
Yeah.
It's still really hard to know what to do with this from a primary care standpoint.
I know. I mean, even for us, it's very, very hard. So I think the easy part is to test, and we talked about the various ways to test. But sometimes the question becomes, what do you do with the results? So when you have somebody with a negative test result, but they have dyspeptic symptoms that don't respond to dietary manipulation or acid suppression and things of that nature, clinically they're likely to have H. pylori infection. Because as we talked about, it's a vitally prevalent infection. But if you can't prove it with a test because they have a negative result, then the question becomes, well, what do you do with it? There's some clinicians that have advocated for just treating them regardless of test result. But with concerns for antibiotic resistance and so on, the societies do not recommend that. But I know if, in my previous practice, one of our partners did that routinely. He didn't even test. He just, anybody with any form of dyspepsia, he just treated. But that's not a recommended approach.
So the ACG guidelines for testing long-term PPIs, is that before you start? But how do you know it's going to be long-term when you start?
Right. So it's people, for example, with Barrett's esophagus. So let's say they've been diagnosed with Barrett's. They're going to stay on it essentially indefinitely. And then those patients is worthwhile to test. Patients are going to be on NSAIDs long term because they have rheumatoid arthritis or some other kind of inflammatory arthritis. So those patients, I think, is worthwhile testing also.
Which brings up, I don't really know, there's a fair number of people on long-term antacids in primary care. So if you, it certainly could test somebody who's been on it for 5 years, But what's the corresponding guideline for scoping somebody just because they've been on PPIs for a long time? Is there such an indication?
No, there isn't. And clinically, I mean, the only reason I think the two reasons for endoscopy in these patients are in a low-risk patient with their alarm features. You've tested them and you've had a positive test result and you've treated them. And then they have persistent symptoms. And then you've retested them, and now it's a negative result. So it was previously positive, treated, now it's negative. But they still have symptoms. Then that's somebody that would need endoscopy.
Right.
Or in patients where there weren't any alarm symptoms previously, they were treated, and then now it's 2 years later, and now they're starting to have weight loss or decreased appetite or some of the alarming features. And even if they initially eradicated the infection and they felt fine afterwards, some return of symptoms would be an indication for endoscopy. But in asymptomatic patients, or in patients who were symptomatic, you've treated them, symptoms went away, I don't think we need endoscopy.
Great, thank you. I'm sorry I got to run.
What is your take on long-term PPI treatment? Where are we at with guidelines on
Yeah,
that?
so I spend, when I'm in the office, at least half of my time counseling patients to get off PPIs. Because I keep telling patients, So, I mean, we've all had these frustrations. PPIs were never designed as a lifestyle drug. In other words, it wasn't meant for patients to take so that they could tolerate big, huge meals and spicy food. And that's how it's used by many patients. So unless there's a clear indication for long-term PPI therapy, a Barrett's esophagus, or this, they've had gastric adenocarcinoma, or they have peptic ulcer disease, unless there's a clear indication, I try very hard. And I tell them about the recent data that's available with chronic kidney disease, and there's an association with dementia. There's a known risk. We've known about this for a while with osteopenia and osteoporosis. There's an increased risk for pelvic and femur fractures, especially in postmenopausal women. So I tell them about all these things. And some patients I just refuse to refill the PPIs because some patients just are so kind of almost addicted to it. And they feel that they need it to survive.
Well,
And generally speaking, it's not the case.
And they can't get past that 2-week rebound.
Right. So I've been
Yeah,
recommending a lot of these kind of the alternative approaches, which there's actually a clinical trial going on apple cider vinegar. So it's an old, I believe, an Italian remedy or something like that, where you take a teaspoon of apple cider vinegar in water twice a day, and that helps with dyspepsia symptoms. And there's a lot of anecdotal evidence, and our patients have used it, and it seems to help them. So I actually recommend it to other patients too, and it seems to work. I would say the majority of the time, and that's
Do you
much
ever
less.
taper them on a PPI and then have them take an H2?
Right, so like on-demand dosing. So yeah, we do that. So people who we take twice a day, we get them down to once a day, and then once every other day, and then we go to on-demand dosing, meaning you only take it when you have symptoms. So I tell them when you have symptoms, you take it for 3 or 5 days in a row, and then you stop it, and then wait for symptoms to come back again.
Well, with all the options over the counter now, there are a lot of patients out there on,
Right, absolutely. I
the
agree with
over-the-counter
you.
dosing.
Yeah, and I actually have a problem with that, and there's increasing clinical data that this is problematic, but it is being used as a lifestyle drug, as I said. It's meant to cover up bad behavior, bad dietary choices and bad lifestyle choices.
As far as ordering the 2 tests in Cerner, the serologic and the stool, can you type in Pylori? I mean, what?
Yeah, both of them pop up, yeah.
But the 2, just the 2? Then-
Right.
Okay.
Yeah, so we primarily do the stool testing.
Right.
Because I think for us it's a little bit easier when patients come into the GI office and we order a stool test, they don't really mind quite so much, I think. Maybe more challenging in the primary care unit.
Probably not that big of a deal on that. It just requires a trip back usually
Right.
with the sample.
Right.
Do you
Yeah.
always retest after
Uh,
treatment?
No, just in those patients that we were talking about where there's either persistent symptoms or somebody has mild lymphoma or cancer and so on. But
Gotcha.
yet routinely it's not required.
Thank you.
Good deal. Thank you.